Hello, everyone. My name is Teresa Rickard with Jones & Roth. I want to welcome you to today's healthcare webinar. Today, we have the privilege of hearing from one of the leading experts in the medical practice management field, Elizabeth Woodcock, about the reimbursement landscape for medical practices this year. This is a great opportunity to get expert advice, and we will also have a brief question and answer session at the end. So please submit your questions in the GoToWebinar control panel at any time throughout today's presentation. I also want to quickly mention that we do have a PDF of today's slides available for you to download in the handouts section. And before we get started, just a quick intro to our healthcare practice advisors here at Jones & Roth. Our practice success plan is a proactive service plan that provides year-long value to practice owners and administrators, maximizing your operational and financial performance. We also support the personal success of practice owners through integrated tax, retirement, and financial management planning. We would like to thank our generous sponsor for making this presentation possible. The law firm Watkinson Laird Rubenstein provides a broad range of legal services to healthcare practices. With expert knowledge of the complex regulatory environment, their healthcare attorneys help navigate the challenges of operating a healthcare practice. Well, today I am really pleased to welcome our guest presenter. Elizabeth Woodcock is a speaker, author, and consultant who specializes in helping physician practices achieve and sustain patient satisfaction, practice efficiency, and profitability. She is nationally recognized for her outstanding presentations that are aimed at improving the business of medicine. She is also the author of 16 best-selling practice management books. Her extensive education and expertise combined with her humor and engaging delivery make her a highly sought-after speaker. In short, we have a practice management expert here with us today, and we are really privileged to have you join us today. Thank you, Elizabeth.
Thank you so much, Teresa. And I wish I could say I had a beautiful background like Teresa does. So I'll spare y'all from seeing my awful office by turning off my camera. But I did just want to say hi before I did. And just so thank you for the opportunity to be here. Everyone has such busy schedules that it's just such a privilege to be here today. And we're going to be really talking about a lot of different areas of practice management and really focusing in on reimbursement, because like many things in healthcare, each and every year we have some significant changes that really impact your payments. And that's what I did together, was put together a program to really convey those reimbursement changes, hopefully in one very short period of time. As we mentioned, we'll have a Q&A period, but don't hesitate to reach out afterwards, because I do find that some of these, since we'll go pretty rapidly, you may need to take a little bit deeper dive into as to how it impacts your practice. So we'll start off with telemedicine, something that we've seen a lot of changes, of course, with the COVID pandemic. Before that, less than 1% of Medicare claims, for example, were telemedicine based. And now we're seeing some specialties like behavioral health, in particular psychiatry and psychology, that are really kind of coming out at about 60 to 70% of remote services. We'll talk about telemedicine and then dig right into Medicare reimbursement. We're only about 45, 50 days outside of the new year starting in 2022. So we're just now seeing those remits come in. So what changes do we have from Medicare? Sequestration, speaking of Medicare, is a big deal. So what's the future of that? And then we'll talk about the real increase of advanced practice providers. Of course, scope of practice is at the state level, but we're seeing some changes at the federal level as well. Now, you've probably taken a deep dive into the NSA, the No Surprises Act, because it did begin on January 1st, 2022, but just kind of highlighting some of those changes and the reimbursement challenges that we have, and making sure that I give you those resources. The Quality Payment Program, which is the umbrella program for the merit-based incentive payment system. Certainly want to talk a little bit about that. And then importantly, CPT codes, the changes for this year. And then I want to hone into sort of what's going outside of the payer market that is definitely making some changes, the competitive landscape that we're seeing, and then the growing financial accountability of patients. Now, I don't know about y'all, but I hate to go to educational programs where somebody's kind of talking about things and I'm like, well, I really, really want to know more. And if I don't have the resources that really come from the horse's mouth, it drives me crazy. So you'll see on these slides, and as Teresa mentioned, you can see and get that handout right there, that PDF. It's right on the Go to My Webinar console. And so you can follow through. I've really put, I think almost every slide has that extra resource so that you can delve deep into any one of these issues that you feel like is really going to be impacting your practice. So just about a month ago, the government did announce the renewal of the public health emergency, something that we thought was going to happen, but always seems to happen at the very last minute. These PHEs do stem from the federal level, and it allows us for a 90-day period. So a public health emergency is a 90-day period for us to basically be exempt from everything from HIPAA to reimbursement issues and everything in between. We don't know how much longer these public health emergencies will indeed roll out. And I should clarify, I don't mean that you're exempt from all of HIPAA, but indeed, when you are performing services that are remote, there is right now an exemption from the sort of basic tenets of HIPAA, because before you would have to, have sort of all kinds of qualification to make sure that the patient on the other end of the line was indeed your patient. And that included, you had to see them in the office first before you even did telemedicine. Well, as you know, if you're familiar with telemedicine, now for about 2 years, actually, we've been able to pretty routinely be able to provide that and receive the same reimbursement from Medicare as you would for an in-person service. But again, that's because of the public health emergency that extends just for 90 days. So we expect to hear again in April whether or not they'll extend that for another 90 days. But I did want to point out that the government in the interim, and this was started by the Trump administration and continued by the Biden administration, has allowed certain CPT codes to actually extend beyond the public health emergency. So you can go to this URL that I've given right here on this slide number 6, this https :// etc., and see the Excel spreadsheet that has 272 CPT codes on it. And it actually walks you through, it's a pretty easy process to take a look at. I've given you a screenshot here, and you can see that there are a number of codes that are now available for billing through telemedicine and receiving the exact same reimbursement that you would for a face-to-face visit that are available through December 31st, 2023. And what I like about this is instead of sort of being on our toes, scared to death, is this going to be ending in the next 60 or 90 days? It's giving you enough of a runway that if you do want to perform these services via telemedicine, you have a good, 23, 22 months left to do it without wondering, is something going to happen in the interim that may change my reimbursement? So again, great resource that is available that gives you this list of telehealth services. Now, this is a Medicare list, but I do find that many of our commercial payers are piggybacking on what Medicare is doing. And even if they're not, This is something that I recommend in the billing office that you know about, because you can appeal for services, appeal any denials by saying, hey, listen, even the federal government is paying for it. Here's information about that. Here's a screenshot, and you can see that the reimbursement is indeed available. So it could be a great tool that you can use in your business office for appeals with commercial payers. So I did also want to point out that the government is now wrestling with the reimbursement for telemedicine services on a long-term basis. Unfortunately, for those of you who do want a little bit more breathing room with telemedicine, the the research entity, the nonprofit entity that was set up to advise Congress about healthcare issues, is an organization called the Medicare Payment Advisory Commission, or MedPAC. And MedPAC, as you can see, I've just highlighted some of the terms here, is actually recommending that the government go ahead and rein back in these telemedicine payments. Now, has the government done anything? At this moment, no. So the federal government hasn't made any changes that are sustainable at this time, other than what I mentioned about this spreadsheet having some services that they've extended through next year. But there's a lot that's on the table. Let's just take some examples where the patient can even be. If you go back to before COVID, before public health emergency, the patient had to be in a healthcare professional shortage area, and they could not be in their home. They had to be at a facility like a critical access hospital, for example. So it's very specific definition for where the patient could be located, what device they had to be using to go ahead and do this telemedicine visit, what services were available, what providers could do it, on and on and on. And what's really interesting, of course, is that not only do we have this set of issues that we need to wrestle with regard to the federal government, but every state, including Oregon, has particular laws that relate to what can be actually given, what services can be given via telemedicine based on the provider's scope of practice. So scope of practice is handled at the state level. And so we could go and take a deep dive into any one of these issues. But what I mostly wanted to conclude with is we don't know. We don't know what the future of telemedicine will be today. We hope that by the time the federal government stops issuing these public health emergencies, that there will be enough pressure on Congress to really be able to give us some more relaxation about reimbursing for telemedicine. And part of that, as you and I both know, is that patients are now expecting it. They've had it for almost 2 years, and so it's really going to be hard to rein back that genie in the bottle. So let's go ahead and talk about Medicare reimbursement. I think it's important to pause here and say, wow, you might be a pediatric practice, or you don't even take Medicare, you're non-par with Medicare. Like, why would this matter? Well, we know in the United States that we do not have a single payer system. We also, however, know that about 20 years ago, when the federal government really leaned into what we call the resource-based relative value scale, right? We all talk about work RVUs. That's how most physicians are actually at least partially compensated if they work for a hospital or health system now. So this scale is kind of built into the fabric of reimbursement. It is actually a Medicare scale. And so as Medicare makes changes, that makes changes to the resource-based relative value scale, which now affects not just Medicare reimbursement, but actually the majority of our commercial payers are now tied now tied to the scale as well. So in essence, what I'm saying is Medicare really is the bellwether for all payers, not just government, but also our commercial payers. And so when we see changes to the conversion factor, that is rippling out and affecting not only your Medicare business, but also, of course, Cigna United, Aetna, Anthem, et cetera, et cetera. So as you can see, we did see a little bit of a decline to the conversion factor. You may not have read a lot about this because, gosh, you would say, well, people would be furious, right? Look what doctors have done. They've been on the front line of COVID. And what do you mean? They're getting paid less in 2022. And I don't know if this was purposeful or not, but about 6 months ago, the federal government announced that, hey, in 2022, we're going to pay doctors 10% less because the way we build up our formula shows that we've got to be budget neutral. And there's just so much Medicare spending going on that we've actually got to reduce the entire kit and caboodle by 10%. Well, as you can imagine, there was an uproar about that. What do you mean you're proposing a 10% cut? This is crazy. And so, indeed, in early December, President Biden signed into law. I love this. We're getting thrown in with the farmers, the Protecting Medicare and American Farmers from Sequester Cuts Act. And what happened is that on December 10th, the government basically reversed its 10% cut. And in a little bit of, I would argue, a sneaky move, what they did was they phased in an almost 3% cut. Yeah, so we got the news that, oh, things are looking pretty good. We just saw that, as you remember from that slide before, it was about 3 to 5 cent decrease. But oof, I want you to be aware that every quarter, or at least the first 3 quarters, the government is introducing little tiny bits of payment reductions. And I want you to be aware of this because if you're working in the business office or if you're an executive at your practice and all of a sudden you start seeing whoa, why is our money going down? We're billing out the same services, we see the same encounters, we're even producing the same RVUs. What are you talking about? We're getting less money. It may be because of this phased in reduction in payments that Medicare is doing in 2022. So again, just want you to be aware, April 1st dates of service, we'll see this additional 1% decrease. And then on July 1st phases of dates of service, we'll see even an extra 1% on top of that. So it's better than 10% down, don't get me wrong, but the government is still introducing almost 3% of cuts for physicians in 2022. Now, every year, based on little bits of tweaks to the scale itself, and again, I'm referencing this resource-based relative value scale, the government does make tweaks to that scale itself. So takes a little bit down, takes a little bit up, that impact particular CPT codes. And if you are, for example, an IR or vascular surgery, and you do a lot of the CPT codes that are getting decreased, well, as you can imagine, then your reimbursement is going to get decreased as well. So as you can see, our big winners were diagnostic testing facilities that get paid off of the professional fee schedule. So this would be like a non-hospital based testing facility that is still running off of this pro fee schedule. And then, unfortunately, for interventional radiologists and vascular surgeons, who, as y'all know, actually often share CPT codes because they perform a lot of the same services, those CPT codes had reduced reimbursement or reduced units in 2022, and thereby you will see that drop of about 5% 5%. And it's an approximate, an estimation, because what the government does is, as you can see from this display, I've given you all of the different specialties. And these, of course, are listed by what we call taxonomy codes. So the government kind of groups specialties under taxonomy code. I know that they're not particularly grouped under what you may do your residency or fellowship in, but this is how the government administratively codes them. And then they make an estimate of the impact. And I do want to make sure that I reiterate for IR and for vascular surgery that indeed these are the actual units themselves. So if you get paid by Cigna or Aetna or Blue Cross Blue Shield based on the Medicare fee schedule or based on relative value units, you'll see those same impacts from the other payers, not just Medicare. That's why I really think that paying attention to Medicare reimbursement is so absolutely critical each and every year. So these are on your handouts, but I wanted to just literally provide the screenshot. And then as you can see that source at the very bottom, if you want to just go right to the horse's mouth, that's going to send you right to, it's about a 2,000 page document, the Federal Register, but you'll be able to find this chart right in there. And speaking of great tools, I was just using this yesterday when I was working with a physician organization that is part of a hospital here in my state of Georgia. They had been told by their endocrinology department that never, ever should an endocrinology practice make money. And so, that gave me pause because I've certainly seen a lot of endocrinology practices make money, but they didn't know like how to tackle it. Like, what should they be getting paid for, diabetic education services? What should they be getting paid for the physician, even just seeing a patient like a 99213? And I want to make sure that y'all recognize there is an amazing lookup tool that CMS does offer to us, and you can go on it and you can type actually for any year, so you can look back and see like, that's really odd. Here's what's happened, for example, to our surgery. It used to pay 5 years ago XYZ amount, and today it pays ABC amount. And this is totally free, and you can do this at the geographical level. So if you're in Portland, for example, and there may be a different rate if you have a site, for example, in Vancouver, Washington, you can actually see right within instant the reimbursement for Medicare for both of those locations by CPT code. So I use this all the time. Every day I'm referencing this. And because it's hard for us in healthcare to get reimbursement for anything, prices for anything, this is like the one tool that we can have access to very readily. So I highly recommend it. Another resource I highly recommend, particularly if you're in a specialty that is offering preventive services. So I'm thinking general internal medicine, I'm thinking cardiology, thinking GI, for example. There's a fair amount of confusion. OBGYN is another one about like, what does Medicare pay for without any cost sharing at all? So in essence, it's free for my patients. How often can I do it? What is the frequency that they're paying for? Everything from smoking cessation counseling to DEXAs. And the government has actually put this in a very, very easy to use tool that gives you all of the details. And I did want to make sure I pointed this out. And another little tip, and I got this from a great internal medicine practice, is what they did was they went through as part of their population health initiative and went through all of their database for their patients and said, well, who hasn't, for example, had their annual wellness visit? Or who is a smoker that we haven't offered smoking cessation counseling? So basically, they gathered these lists of patients. And then what they did was, in addition to, if the patient came in for something else, they would always kind of mention it during the visit. But in addition to that, what they did was give that to their schedulers. And when they had a cancellation on their appointment schedule, the schedulers could then have a list of patients who were due for services that had no out-of-pocket cost. And they proactively called these patients and said, "Oh, Miss Woodcock, you're actually due for your Welcome to Medicare visit. It's a free visit for you. We do have an opening tomorrow at 1 o'clock. We just thought we would offer this if you're interested in this." Again, no out-of-pocket cost service that we offer. So like, what a win-win. Really enhance their population health initiative and help them prevent those empty slots that were sitting there from canceled appointments. So just thought I would mention that's a great, great suggestion. And that's a wonderful, wonderful website that perhaps may be new to you. So this pesky sequestration that actually has been with us since, if you can believe it, 2011. And sequestration, basically, if you look at your Medicare remittances, you will see that the government takes 2% off of all of your payments. And fortunately for physicians, that did stop in May of 2020, after the pandemic had hit and the government was looking for ways to basically kind of, lean into helping you financially. They stopped, they put a halt on sequestration. Unfortunately, though, it's not like the government didn't still need that money. And so it was really just a stay, a halt, a hold. And so we are seeing sequestration come back. And as I explained to you, that is indeed what they're rephasing back in as the reduction in 2022. And unfortunately for us, because they held off for these 2 years, physicians will see that on their remittances as a reduction until 2030. It was supposed to end in 2025, but indeed it did not. So how are you seeing those on your remits? It is a CRAC, which is a claim adjustment reason code, and that is actually you can see those on your remittances as that -2% payment. But I did want to mention just really quickly that I am seeing sequestration, and if you could see me, I'm in air quotes, being actually taken out of non-Medicare payments. United Healthcare, for example, was doing it for a while. And I think it's because, honestly, they could just get away with it. And they would mark it as the CO 104 managed care withholding. Y'all, that they shouldn't be doing this. So, this is something that I recommend for every single practice is at least once a month. Okay, if you don't have time, then at minimum once a quarter, just flip through your remittances. You may have to flip through them electronically because most of the time we get everything, it's never on paper anymore. So you have to flip through it electronically. But I want you to see, why are monies being taken away from you? And oftentimes it's in these like cryptic codes like the CO 104, but you can just follow it back. And I mean, just Google it, CO 104 is claim adjustment reason codes, and it'll pop immediately about what it is. But really, really don't be taken advantage of, because I think since our insurance companies know that, not a lot of people are looking at these, it just is, well, I'm biased, but it's a sneaky way to take money from you. So definitely want to put on your action items to at least take a look at your remittances, especially as the new year has turned. Now, there is a huge document that is available. It's about 2,000 pages that really goes through all of the changes in 2022. But I did want to hone in on the summary document. And as you can see, I've given you that as a resource. You can just really quickly copy and paste this URL. And I think it's again, just worth your time. I have it's kind of embarrassing to say, but I have mine on my nightstand, and I like before I go to bed, I'll read, okay, what's going on, just to kind of familiarize myself with all of this. And I do think it's well worth the opportunity. And I really just want to point out a couple of things that might be of interest. The first is that we do see a marrying up of the reimbursement for physician assistant services to be consistent with other advanced practice providers like nurse practitioners, in that PAs can now bill directly to Medicare. So this is important change, and I think it does signal one other change that the government is making to really loosen the regulations regarding advanced practice provider billing. Now, this doesn't mean that you're going to get paid at 100% of the fee schedule from Medicare. You will still get paid the 85%. But what it does mean is that there is the ability to actually bill and receive reimbursement directly for PA services. I'm referencing here another chart from MedPAC, that governmental entity that I was telling y'all about a few minutes ago, that does actually kind of give advice to Congress about healthcare issues. And I know y'all are well familiar with this because, of course, you're practicing in the Pacific Northwest, where we've seen a lot of APP billing and reimbursement, but really across the country. I mean, look at this. Almost in a 5-year space, a doubling of the services for encounters per beneficiary. This is focused on Medicare, coming from our advanced practice providers. So we're seeing a lot more of this just actively across the country. And fortunately, I am seeing medical practices be able to go to their commercial payers and negotiate 100% of the physician fee schedule in terms of reimbursement from their commercial payers. And so it enables us to kind of get out of this craziness related to incident to billing and really just have the APPs billed directly. Now, again, I want to repeat that that's not applicable for Medicare. You'll be seeing an 85% reimbursement. But I did want to make sure that I mentioned that many practices with which I work have been successfully able to negotiate 100% of the physician fee schedule for their APPs from commercial payers. So if that's not something you've explored in the past, I would certainly recommend it in 2022 because, well, honestly, market dynamics on your side, there's just simply not enough capacity in healthcare. And so APPs are really being able to provide access. And so our practices are able to go directly to their payers and negotiate that to their advantage. Now, indeed, speaking of APPs, we are seeing a change with split and shared services. This is sort of like, well, incident 2 is on the outpatient side, and indeed, split and shared services is really on the inpatient side. So if you are an oncology practice, for example, pulmonary critical care practice, and you are performing a lot of split shared services, definitely want to make sure that you hone in on that final rule, because it's a phased in approach in terms of these changes. But the government is asking for a modifier this year, F as in Frank, S as in Sam, to be put on split shared services. And as you will see, it's no more billing just based on the doctor. We are seeing that it will be by 2023 the provider who is providing the substantial portion of the visit. This is a big change for some of our practices, again, particularly oncology, critical care, etc. So we were talking about the No Surprises Act, and certainly I'm sure many of you have been on plenty of webinars about this. But indeed, if you haven't, it's really important for you to get educated about this because it's fairly broad reaching. And I say that because I'm hearing a lot of practices say, well, it's okay because, we don't see any self-pay patients, for example, or we don't do out-of-network billing. But really, No Surprises Act has a much broader implication than just those practices. So I would encourage you to take a look at I think actually the government has done a fairly good job of the resources that are available. And you have to have good faith estimates now for many patients. We have entire health systems. I was just talking to the team, for example, at Duke Health, and they are doing good faith estimates for every single patient. And they schedule 4 million a year that comes to their outpatient clinics. All 4 million will indeed and are now getting a good faith estimate. So really want to hone in on when you have to do this, making sure that you're complying. And then I would encourage you to actually go to these great resources the government has put up. And I've given you the URL to go directly to the horse's mouth. Now, I did want to spend a few minutes talking about the quality payment program and the QPP, which it's sometimes better known as its component part called the merit-based incentive payment system. It can be a really complex program because there's a difference between the performance year and the payment year. The performance year is 2 years before the payment year. So we kind of like almost right now have to talk about 3 different things because the performance year 2020 is what you're seeing in terms of reimbursement for 2022. The performance year 2021 is what you'll actually be reporting for now, and the portal will be available through March 31st. So, you need to be aware of 2021. And then, of course, right now, you're in the midst of going ahead and reporting for performance year 2022. And you might be like, well, I mean, really, who cares? But what's at stake right now, and honestly, it's in perpetuity, is 9% of your Medicare reimbursement. So that's not a plus, that's a minus. So it's definitely important to at least pay half attention to this to make sure that you don't get penalized. Just about 2 weeks ago, the government did go ahead and publish the results of the 2020 performance year. So again, when I talk about the 2020 performance year, what I'm talking about now is what today on 2022 you should be seeing in terms of payments. And as you will see, I love working with physicians because, I mean, when you say we're going to penalize you if you don't do something right, I mean, they're all in. They're all in. And if you say, well, we actually have a section of our program for exceptional performers, the first thing that you get is a bunch of hands up that say, yes, I'm an exceptional performer, so I'm in. And so, indeed, as you can see from the data, 85% of physicians who qualified and participated in this program did reach the exceptional performance zone. A little bit of bad news in that, gosh, that's an amazing result. Well, how much did you get for it? Well, the maximum adjustment. So for those who got a perfect score on what is a fairly complex program, got a 1.87% bonus. On the flip side, if you, for whatever reason, didn't actually participate and you should have, well, unfortunately, you got a 9% penalty. So, in my opinion, this is a little frustrating. On the good news side, if you participate as a individual in the program, you are actually automatically exempted because of COVID for the last 2 years from any penalties. So I think that is absolutely great news. We are not anticipating that to be extended to 2022. So just to put on your radar screen, there's kind of this application that you can do that says, listen, I've had a really tough time with COVID in my practice. It's really turned us upside down. And honestly, all you have to do is say yes. You don't even have to explain why, that you've had a quote unquote extreme and uncontrollable circumstance, and you can be completely exempted from the program, which then exempts you from the penalty. So if you are, like, I have no idea what she's talking about, I've got to make sure that I'm not penalized for all my Medicare reimbursement, then make sure you put this on your calendar. These exemption applications usually open during the summer and they close at the end of the year. So again, make sure you apply this year, because I don't think we'll see that automatic exemption again. If you did participate and you did all your reporting despite all of the craziness that 2021 held, just know that you have until March 31st, as you can see at the bottom here, for you to go ahead and submit your reports. Make sure that you put that on your calendar, because again, I just want to make sure you don't get penalized by that 9%, because that's a really nasty penalty. So this year, now we're talking about what you should be doing today, unless you plan on applying for this exemption. I do want to make you aware that if you do have midwives, if you do have clinical social workers that are billing Medicare, you need to add those to your participation. And you want to make sure you recognize that you've got to get to 75 points in the program in order to be exempt from any penalties. So that threshold, that bar got higher this year. It got moved up to 75 points. Now, we don't have the opportunity, given our time today, to delve into all of these categories and what you need to do to apply. But again, I actually think the government's done a pretty good job. So I'm going to encourage you to go to the Quality Payment Program's website. But I'm also going to ask that you recognize that 1.87%, last year it was 1.79%, every single year for the last 4 years it's been less than 2%. This is the final year of the government's 5-year funding for the exceptional performance threshold. And so basically, even that 1.87% is going away after this year. And so I do think it really compels a question within your practice as to what is the business case? What does trying to get a perfect score cost me? If, for example, I've hired a RN and all he, she, or they is really working on the quality payment program, and I'm paying them fully loaded $75, $80, $100,000 to do this. I mean, unless you are a massive health system, because that exceptional performance bonus is going away next year, you're never going to get reimbursed. You're never going to get the cost for that person back. So just recognize that you want to make sure you avoid the penalty. But after this year, you will basically get nothing for exceptional performance. And I do think it's at least a conversation that is worth having within your practice to see if the juice is worth the squeeze to get all the way to that perfect score. Again, make sure you comply, but maybe not get to the 100%. So we are seeing some changes in CPT this year, very, very minimal compared to last year, and very heavily weighted to the COVID vaccine for obvious reasons. So we had 24 vaccine specific codes added. The easiest way, is obviously to make sure you really hone in on your resources that are available from your specialty society. The American Medical Association, who of course is the author of the CPT manual, does issue the CPT changes report each and every year. I love to get this because it just gives me that kind of reference to see what the changes are, and then it gives you a lot more information about them. Couple I wanted to highlight is that the chronic care management services has been, it's actually been loosened a little, and it does give us this kind of add-on code when I have more than 30 minutes that I am performing for the patient per month. I can actually use a unit of each additional 30 minutes. We also know that the government has been paying for remote patient monitoring for some time. It was physiological monitoring. Now they've added an entire set of codes for therapeutic monitoring. So this really is opening a lot of basically home-based care that many practices are taking advantage of. And I say that because, oftentimes the practice is actually performing these services. It's just nobody knows how to get paid, or even if they could get paid. So if you're doing a lot of, phone calls with your patient, telemedicine, virtual visits, for example, just make sure you recognize that there's like this whole host of codes that are available for you to use. They may not all get paid, but many of them do. And in fact, the American Medical Association has even introduced a whole taxonomy for digital medicine services. So as you can see, this really is certainly is foreshadowing the future, where we see a lot more services that are being performed virtually, able to bill and be reimbursed for. I did want to make sure I pulled up these RPM codes. Very successful practices are billing for these and getting paid successfully. These have been out for about 2 years. And again, now we're really being able to add not only physiological monitoring, but also therapeutic monitoring. The nice part is you don't have to have this consent each and every visit. The government is allowing kind of a blanket consent to be able to offer all of these services. Now, speaking of all of these services, I did want to point out that we're really seeing a huge change to what I would call kind of a disruption to our a legacy or incumbent healthcare delivery system, right? We have our hospitals and our health systems and our medical practices, but things are changing incredibly rapidly. Part of that has to do with what is happening in the private equity market, and of course, what is happening as well for our publicly traded companies. And the left side of the screen, and I could have chosen 100 more startups and newly minted companies, so early stage companies like Heal, Village MD, Maven very focused on the femtech or feminine technology industry. So lots of early stage companies, as well as these very well funded publicly traded companies that are leaning in big time, not just to healthcare, but actually not just insurance, but the care, the delivery of care. So Best Buy Health is a good example. They started off by buying a nurse call center. They purchased a telemedicine company. Of course, they already come with technology, and now they are really into the remote monitoring field big time. And I mean, the Geek Squad, which is owned by Best Health, may now be actually coming to a neighborhood near you and plugging in all types of, pulmonary function tests and all kinds of new things, because that's really where the market is going. Another big area that I'm seeing a big shift is these insurance companies that are actually purchasing telemedicine companies, or certainly aligning with them. For example, Cigna did buy MD Live, and they're actually partitioning out to other insurers. And I think this is important because these insurance companies are quite often offering telemedicine services with no copays. And so your patients can actually receive services and have to pay a copayment to you at the medical practice and not have to pay a copayment for their telemedicine visit. And so, again, you might say, well, gosh, Elizabeth, I'm in this remote area. We don't have all these fancy things coming to our location. But actually, I would argue that this isn't just happening in, Portland and Bend and Seattle. It's actually happening in what we now term healthcare deserts. This is kind of the big target for many of these companies, that they're really, really focusing in on where care is not not coming in. And so Dollar General, which is a big player in these healthcare deserts, they've hired this really kind of high powered ex McKinsey anesthesiologist who is now their chief medical officer and is rolling out their healthcare strategy now. So lots of partnership, lots of changes, really creating these new competitive landscapes that may not actually compete against you, but maybe kind of happening what might have been in the back of your mind now may start changing the way referrals are actually being distributed within healthcare deliveries. You, for example, if you are in reproductive endocrinology, you may, instead of getting sort of your typical primary care OBGYN referrals, you may see a lot of referrals now coming from these femtech companies. So I did want to make sure that I just kind of explain what's going on in this landscape, because it is changing reimbursement rapidly for medical practices across the country. And certainly, we've seen a lot of changes in the past to who owes the bills. Historically, it was insurance companies, and particularly because we're seeing a tremendous amount of changes with regard to employment status. I mean, basically, patients are changing. The data shows us 1 out of every 4 patients that you see in your practice today will be with a different insurance company than they were last time when they came into your practice. So, absolutely crucial for you to have all of the eligibility processes that you need in play, and then making sure that you have really, really good workflow to collect from patients deductibles, coinsurance, and copayments. And you might have been really good about that for your in-person encounters, but where I find is that a lot of practices that very quickly ramped up their telemedicine and other virtual medicine services have had to now kind of go back and recognize, okay, right, if I see all my patients over Zoom or whoever, Teledoc or whatever service you use, well, I got to make sure that I collect the co-payments for those. How do I do that? How do I do that? And I think increasingly we're seeing the patient really defining the success of the revenue cycle. This historically was really defined by payers, and now it is being defined by patients. We had a little bit of kind of a pause during COVID because many of our insurance companies really actually hit pause. They suspended co-payments and the like, but that's not happening anymore. Those companies have rolled back all of those co-payment suspensions, and our commercial payers just simply aren't doing that, honestly, even for COVID related encounters. So watch very carefully your denials on the back end coming through your business office, because we're seeing a lot of denials, particularly because, again, these insurance companies have stopped covering all of this treatment. They're passing off the cost share to indeed patients. And then I think one of the really interesting kind of outcomes of COVID is these insurance companies have made honestly a killing. I mean, you look, I just took this snapshot last week of what's going on with United Healthcare. And I mean, you can see, right, the stock price has just soared. And it really makes sense when you think about it, because during the pandemic, we were all still paying United Healthcare our premiums, but we weren't getting care. I mean, for a while, we weren't even allowed to. We had to stay in our houses, right? Many of us were scared. We put off services. I know I was one of those patients. And so now that all of that pent up demand is coming into play, United Healthcare is saying, listen, we got to keep our stockholders happy. So, how are we going to keep our stock prices high? Well, one of the levers they're pulling is denying claims. Denying claims. So I don't have an answer to that other than to make sure you have that knowledge and you're watching very carefully in your business office for those denials, recognizing that they're on the rise from these commercial insurance companies, and that you're really having your business office pay very careful attention to working those, to getting them reversed. I find that a good data point to use is that 75% of your denials can be overturned, but sometimes it takes some effort. So definitely seeing those increases, making sure that you do have both planning and execution so that you're able to not have, you know, ugh, United Healthcare is keeping their stock prices high affect your practice. So I want to emphasize eligibility processes, not just in your office, but when your doctors are going out to the hospital, the skilled nursing facility, nursing homes, dialysis centers, as well as seeing patients over telemedicine, making sure that you have those eligibility processes honed in, really successful, because honestly, you're fighting against the insurance companies that have an economic incentive not to pay you. Now, there is this really interesting piece of technology that is available that I'm finding practices just certainly aren't aware of, that I wanted to mention just really quickly. It's often called discovery. And the vendor you may want to ask this of is your clearinghouse, your clearinghouse. And basically this is a piece of technology that you can bolt on or, turn on, and it allows you to take all of your self-pay or anyone you've received a denial for eligibility, and it runs them through databases to see where their insurance now is. So it's kind of like a, almost like a database lookup process. But what I love about it is it's given practices a really, really nice tool to deal with some of these pesky eligibility denials and these self-pay patients who may have insurance, but you're not aware of. So lots of other opportunities on the revenue cycle side. Great idea to focus on the patient financial experience instead of quote unquote collections. Wonderful idea to really be able to offer some team incentives. I love the eligibility certification, kind of a give back to your team members, to your employees, to really allow them to grow professionally. Why not throw up a new title? Right? Not just a front office representative, but a front office specialist if you've been there for 2 or more years. These are things that you can do without a lot of cost that really can make a difference to your patients. So what we've done is we've been able to run through all of these different categories that really are impacting your payments in 2022: telemedicine, Medicare reimbursement, sequestration, APPs, the No Surprises Act, Quality Payment Program. We've hit the highlights of the CPT codes and also kind of really pushed our minds a little bit and talking about what may have been in the background during COVID that has kind of created this new landscape that may not affect us today, but I would argue it will possibly affect us tomorrow. And last but not least, what's been happening with patient financial accountability and how that Wall Street thing going on with United Healthcare and Cigna and Aetna and all of our other payers may be impacting your practice. So would love to kind of flip into our Q&A session. I'll turn it back over to Teresa. And as I mentioned, definitely more than delighted, as you can see from this slide, any question that requires intensive research, would love to be able to take your name and respond specifically.
Great.
Teresa?
Thank you so much, Elizabeth. That's fantastic. So many great takeaways today. And I know this topic does often bring up many questions. We all already have a number that have come in. So if you are able to stick around for the Q&A session, we would love that. Also a reminder, we will send out the recording with the full-sized slides, and we all also uploaded those to the handout section. So let's jump into the first question. If a patient is treated via phone only, can we still bill 9921X?
Yeah, so that's a great question. And so I think the 21X is 212, 213, 214, et cetera. And so again, what I would certainly ask that you do is to take a look at that code that we have, or excuse me, that spreadsheet that we have. And I think this will allow me to share my screen. I
Yes.
want to be able to hone in. We're talking about 992. There's no more 99201, but you can see, can audio only interaction meet those requirements? And that does not include those codes. But if I may just really quickly point out that there are some beautiful codes that actually are available for phone only codes. And so this is what I would encourage you to do, at least for the PHE. And honestly, they're actually paying at higher levels than our low level E&Ms. And you can see 99441, 99442, and 443. And what I love about them is our physicians can bill for them as well as our APPs. That QHP means qualified health professional. And you can see these are based on time. So our 99, just to make sure I point out, 99441, 99442, and 443, that's where I would actually encourage our listener to go ahead and look at, because those audio only interactions do meet the requirements. Teresa?
Great. Elizabeth, this next question, I actually chatted to you because it is a little longer and more technical. I'll do my best here to ask it. But this listener understands there is the newer place of service codes that were introduced, but they're not required currently due to the pandemic, the 02 as well as 10. And they're asking, how should we indicate when billing an insurance carrier that this was a telehealth visit? Should the 95 modifier be added? And if so, should that not result in reduction of payment? Will
Yes.
that not result in reduction of payment?
Yeah, that's a great question. It goes back to kind of at the beginning where we're all sort of waiting. Will the federal government actually, like, what are they going to do about telemedicine? Will they go back to the O2, which requires very specific things? And as our audience already said, like, we're actually not using the O2 right now, because the O2 is that like traditional, the patient has to be in like a critical access hospital, and you have to be a doctor, and you have to have these, really fancy equipment. You certainly can't be FaceTiming a patient like you can today. So until the PHE goes over, I personally wouldn't be using O2, because it will reduce you down to the facility reimbursement, which is lower than a medical practice should receive. So lots of complexity. Be happy to answer the person's question in more detail. But you shouldn't be getting paid less. It should be the same as the face-to-face encounter, at least today, and that the 95 is that correct modifier to use. Now, that being said, we don't have a single payer system. So you may have rules, for example, with Blue Cross Blue Shield of Oregon or Medicaid, your Medicaid plan that requires something a little bit different. So I am going to give that one caveat to say, like, you got to kind of follow this at the payer level, because all of the payers, I'm based out of Atlanta and I know ours in Georgia, they're making changes right now as to what they will pay for and what they won't, how to bill it, how to not. Ooh, it can get very complex. So definitely want to keep that on our radar screen, especially in the next couple of months, as possibly the PHE gets rolled back. Teresa?
Okay, great. Last question. How can we tell if we're being penalized for the quality payment program if
Definitely
we're
want
not
to
sure?
Yeah, definitely want to take a look at your remittances and know whether they're, because you could see like the minus, and the way you see the minus is there's actually a penalty code for this program, and it is CO as in contractual obligation 237. So that's the legislative penalty. And again, it's all these little codes. So until you take a look at them, you don't even know that, oh my gosh, this stuff is going on. And in particular, if you are getting penalized for the quality payment program, you'll see a remark code that is N as in Nancy 807. Again, N as in Nancy 807. And I will actually go ahead and put that in the chat to make sure that we have those. So it's N807. That is the little remark code that you'll see. So lots of opportunities to be able to make that better. But the first thing is to even know about it. So definitely take a look at those remittances and see if you're getting penalized on this or anything else.
Great. Well, thank you so much, Elizabeth. Like I said, so many takeaways today. We will be sending out a recording and the slides to everyone. And if you don't mind, Elizabeth, jumping down to those final 2 slides and we'll wrap up, I want to let everybody know that today's presentation does meet the AAPC guidelines for CEUs. So if you are interested, please email me at info@jrcpa.com and we'll get that sent to you. And finally, I want to let you know that our summer webinar will be focused on employment law updates. So keep an eye out for registration information, and that will be coming soon. Thank you everyone for joining us today. Thank you, Elizabeth. It's always a pleasure to have you, and everyone have a great weekend.